everybody. This is Glenn Woodworth with the Society for Education Anesthesia Innovations in Anesthesia Education webcast series. And today it's my great pleasure to have Chris Giordano, and he is an associate professor at the University of Florida. He is the division chief for their liver transplantation area, and it's great to have him on because he's got some interesting projects to talk about, and he is a very respected within his institution as an educator and has won multiple teaching awards. So Chris, welcome this morning, or well, I guess for you this afternoon, but welcome.
Thank you for having me. It's great to be on.
All right, so I've got the what you wanted to talk about today. We're going to start off with is how to design or your design for a fourth year medical student rotation that's super popular at your institution. So let's start with that.
Yeah, so I think what I've been able to capitalize on is really developing topics and ideas that are really a capstone experience for medical students. And what I mean is, as you know, as anesthesiologists, we get to get some immediate feedback and gratification on the physiology and pathology and the pharmacology of things. And people going in pediatrics get to see how that happens in the peds room or in the neurosurgery room or orthopedics. And so they put together all these pieces of information and they get to see it in real time. And it's really been interesting for them how they can use this time to become a better physician. And so the second thing I've added to this is really the development of non-technical skills, and particularly ideas about situational awareness, judgment, decision-making, teamwork.
Awesome. Well, let's kind of talk a little bit through those in more detail. So let's start with the first one. You know, pretty much every institution has a fourth year medical student rotation. So how would you say that your rotation differs? Let's not talk about, come back to the non-technical skills, but your first part about sort of the overall experience. I didn't quite get what that might mean.
So the idea here is they're going to do 2 weeks in the operating room and they'll do 2 weeks in an ICU. And what I try to do is pair them to whatever specialty they're going to be interested in or that works well within in both the OR and the ICU. So if it makes perfect sense, I could put them, for instance, if they're going to be going into internal medicine, it's pretty easy. You know, you could put them in most ORs that are general ORs, maybe put them in a cardiopulmonary bypass case, and then they'll spend 2 weeks in the MICU. As it gets a little bit more nuanced, for instance, neurosurgery bound or neurology bound, maybe we'll spend 2 weeks in the neuro ICU and then some time in the neuro ORs. It could get even a little bit more specific. For instance, if you're going into psychiatry, maybe they'll spend a couple of days in ECT. Or if you're going into pediatrics, you know, you'll spend time in the PICU and the pediatric. So they get to really develop their understanding of whatever specialty they're going into. From our perspective and from the surgical perspective or the intensive care perspective.
That's really interesting. Does that take a lot of effort on your part to, I mean, how many medical students do you have for each 4-month block? And how much time does it take you to sit down and organize, or do you have to do something every day to figure out what cases?
No, it's so we have roughly 140 medical students in a class, and it's a mandatory rotation. So that means all of them go through this. And we basically have 2 months blocked out that they can't do it because those are the 2 months where our residents are being paired and trained. And so other than that, those 10 months, roughly, they are divided. They try to be divided equitably, but it's 10 some months, 24 the other month. Okay. And it does take a little bit of planning to get them all in the right places, but we do that a month ahead of time. Okay. And so we'll put them half in the ICU, half in the OR, and then they'll flip. So let's just call it 16 per month, 8 in the OR, 8 in the ICU, and they flip. And we try to match them to their specialty as well as possible.
Do you have to do that on a daily basis, or do you always say you happen to know that your neuro rooms are 21 through 24? They're always going to be assigned 21 through 24. There's a note to the scheduler to make sure they go there. How do you specifically get them into the rooms you want?
Right. So we know so we do this a little bit more based on pairing them with a resident. And we know where the residents are going to be for a week at a time, always, and sometimes for a month at a time. So we'll put them with a resident for 1 week, and then another resident the next week, and then the other 2 weeks they'll be in the ICU. And so
Okay.
if that resident's on their neuro rotation, or let's just say they're on an acute pain service, we'll put them with them so that it works that way. So we do that all a month ahead of time. We verify with the resident,
Okay.
and we give them alternatives too, because sometimes they're in the middle of their week and they're like, I really wanted to see, it turns out this. And so we'll give them alternative people that they can work with and things they can see.
Okay, that's good. I like it. I like the way you've paired them. I guess I had two questions about it that could be cons and sort of how you overcame it.
Sure.
One is maybe our mission is to really teach teach them more about anesthesia. And do you think that by them getting, let's say they were going to go into neurology, that they sort of got an isolated, they did neuro ICU and they did neuro ORs for 2 weeks. Do you think that that gives them enough experience of sort of the overall anesthesia experience, or or not?
So what you're saying is by not giving them a general perspective, they may miss what it's
Yeah,
like to be.
they might not know what OB anesthesia. A lot of other
Mm,
rotations, I suspect, is that they rotate the medical student through a little bit of everything. They want to kind of give them a smattering, a smorgasbord of anesthesia. So they'll do a little bit on OB. They'll do some, over here. They'll do some regional, maybe some acute pain. But they give them. How does that, do you think, match up versus doing a more isolated experience, but in the area that they're interested in?
I think that's fair. I think the that's a big philosophical problem that I think we're all having nationally, and is do we try to create the most perfectly well-rounded student, or do we try to prepare them for what they're going into and
Okay.
create a sort of pathway for them?
Okay.
And I don't know the right answer to that, to be honest with you, but I found that the the acceptability and the appreciation of creating a pathway for their destined future is higher with the students. So they really appreciate that, this is going to be really germane to my development because this is what I'm doing,
Yeah.
as opposed to going into a neurosurgery OR and you're maybe destined to go into.
Psychiatry.
Exactly.
Yeah.
Yeah. And so, I think part of you wants them to see that, but are they going to appreciate it? Is it going to be a good experience? Is it a high yield for their dollar?
Well, I think you probably get better engagement too, because we get excuse me, medical students that will rotate through, and they're not all that interested in anesthesia.
Exactly.
They're kind of slacking, right? Whereas
And I
these,
think you hit the nail on the head with that. Is that part of what I'm doing is this idea of salesmanship, right? I'm sort of selling to them that this is really important,
right?
and they don't recognize it. And the first thing I do when we start off of the month is go around and ask them, why are you doing 2 weeks of anesthesiology? This makes no sense. You don't even know what we do. And then they start pull it together that this is going to be something that's important to them. We're a substantial part of the workforce. Nearly all their patients or family members will have surgery at some point or will know someone who's had surgery. So it's really relative to them to appreciate pre-optimization, post-operative expectations. Are they prepared for this?
I think that's what makes many of us think that they need this general experience, but in the operating room and do different things. But they can still get that experience on 2 weeks in the neuro ORs. They're going to have to go through all phases of anesthesia, from preoperative assessment and optimization to the operating room and postoperative follow up. So I think that probably overcomes that barrier. I
So
did.
I do think that, just to highlight again, they do have alternates that they can go to. And what I do find quite frequently, to be honest with you, is that those specific rooms like pediatrics and neurosurgery, they often will go for the last 2 days to an alternate just because they want to see something different and they are interested. So I feel like there's a little bit of self correction, permitted in case they are a little bit off. And furthermore, I probably get daily, if not that's not true, not daily, at least every couple day phone calls or emails about, can I switch with this person? Is it okay if I move? And if it seems reasonable,
Hate to
it's
say
easy
it,
to do.
but from a faculty perspective, that totally increases the burden of trying to make it happen, because it would be really easy to say, okay, I don't even know who the neuro basic resident is, but I'm going to attach this person to that resident. but then when with a lot of switching going on, and then I got to look and see and who's available, and oh, there's already somebody in that room, and so it makes it a little more challenging, I see, from that standpoint.
Exactly. Yeah.
But I'm sure they appreciate it. The other question I had was, um, 2 weeks in critical care. A lot of the residents will rotate through critical care, I would imagine, as part of their regular medical student. So, why did you choose that experience to do an additional 2 weeks of critical care to be more important than, let's say, doing another 2 weeks in the operating room?
So interestingly enough, when I took over the clerkship as the director in 2015, there was no mandatory ICU time,
Ah,
and which
interesting.
was really interesting for me for two reasons. One, at the same time, our PA school had a mandatory 1 month, and where I trained at in South Florida, it was a mandatory 2 month ICU
Yeah,
experience.
so maybe I'm just thinking of my own experience and maybe
Yeah,
my own institution that it's mandatory, but it might not be in a lot of other places. Yeah,
and students would easily self-select themselves out of an ICU patient or um, uh, general clerkship experience. So all of a sudden, they'll never have stepped foot in an ICU,
right.
and I
Okay.
found that really interesting. So once we exposed it, it wasn't hard to make it happen. The question then became, well, who's going to own the ICU experience? And there was a little bit of interest from the emergency medicine people, of course, interest from the medical ICU people. Um, I was able to put together a pretty cogent um, justification that the didactics I had already put together for the anesthesiology 2 week clerkship would segue seamlessly into the ICU, whether because we did mechanical ventilation, hemodynamic monitoring, critical illness, emergency assessment,
Sure.
airway management. Based the same fundamentals that happen in the ICU happen in the OR.
Yeah. I always say that the anesthesiologist is the ICU physician while they're in the operating room.
Exactly.
Um, do you think if a program already had medical student exposure to the ICU, that then you would do 4 weeks of anesthesia? Or would you still do it the way you're doing it?
That's a really good
Thinking about
question.
transferability. We're trying to see how can we adopt what you've done in other programs.
That's a really good question. I am not sure that 4 weeks. I'm just concerned that 4 weeks would be too much. I think I would have to reconstruct it in a way that would sort of have offshoots of it. So whether it would be OB experience or whether it would be maybe trauma experience, but four
Right.
weeks is a substantial amount of time to be in the OR if you're not going to be an anesthesiologist,
Right. Yeah.
or at
Okay.
least you're definitively not going to be. So
Right.
um,
Well, at least we've given some information for programs that want to do this. Excuse me. I think they definitely, it would be very worthwhile adopting your system of how you match the residents to the rotation, and then you could leave it to individual programs to think about how they wanted to handle the ICU experience.
historically, it had in the 90s and early 2000s, it was a 2 week block that was part of the surgical
Yeah,
experience. And then it got extracted from that for multiple reasons around 2005 and became a 2 week in the fourth year.
yeah.
And so in 2015 is where we got it to that. So that kind of gives you the longitudinal outlook of it.
Probably one other wrinkle is that some programs may have their anesthesia rotation in their third year. If they do it in their fourth year, unfortunately, the medical students that are interested in anesthesia may not ever be exposed to it by the time they got to make a decision, to go into anesthesia, depending on where it occurs in the fourth year. So some programs try to give them. That's why they have maybe a 2 week exposure of anesthesia in their third year. In which case, then maybe one where you're showing them all the different aspects of anesthesia might be beneficial.
I
I did
get
have a
I get at least once a month if from a student saying, "I wish I would have had this my third year, and it would have changed the way I at least considered things, if not
right.
dramatically." So I think that is a really good argument to be had. We discussed it actively about moving this into the third year. It just creates all these frame shift struggles.
Of course. Yeah, it's tough to fit anything in. Now I had another question, which was about your curriculum. So because you mentioned that you've got a didactic, can you describe a little bit about, is it one lecture a day, or what do you do? How do you deliver the didactic sessions? And a general outline of your curriculum. I would say that what we do is we publish supplemental materials with these webcasts. And so if you had like an outline of what your didactic schedule is, we would like to publish that along with that. So why don't you talk a little bit about what the curriculum is like?
Sure. So basically, we have 10 didactic periods, ballpark it. I can go over and get more granular, but about 10 didactic periods that I try to do on Mondays and Tuesdays of the 4 weeks.
In the
And
afternoon, or how
for
are
the
they scheduled?
first, yeah, exactly. The first day is at 7 a.m. And try to be done by 9 a.m. so that I can get them into the OR without too much of a disruption, as well as to get them into the ICU without too much of a disruption, because life has already started well before 9.
Right.
After that, I try to do them between 11 a.m. and roughly 3 p.m. So 2 hours on 2 hour blocks twice. So Tuesday will be or will be 11 to 1, and then 1 to 3. And I'll do that Monday, Tuesday, Monday, Tuesday, Monday, Tuesday. And we'll go through that a little bit more. And I do that on Mondays and Tuesdays, one, to be sort of reproducible, and two, to give them the information a little bit earlier in the week so that they can use it later in the week, because a lot of them, again, are flip-flopping after 2 weeks.
Okay. So you said 2 hours on a Monday and 2 hours on Tuesday, or they're not getting a total of 4 hours,
I'm
right?
sorry. So 2 hours just on Monday.
Yep.
And then every other Monday, Tuesday is basically 11 to 3.
Okay, so a 4 hour session.
Yeah. Now that, no, there's a lunch in there. So really 90 minutes to 90 minutes roughly.
Okay.
But we
Um,
block that off.
and is the style, a lecture series essentially that's given, or is there
You know,
simulation, or what do you do?
we've done as much as we can to get away from the traditional lecture series, just because we've lost a lot of, I think, interest when we do that. And so what I've tried to do is flip the classroom on them.
Hmm.
And so when we initially had these lectures, I then converted them into a PowerPoint that they'd watched the night before, but realized that that was a little incomplete. So then I made that PowerPoint a little bit interactive as a module to watch, and then have questions embedded in it. So they do that the night before, and then they come to the classroom, and it's either a problem-based learning discussion or a team-based learning discussion, or it's simulation. The simulations, as you can imagine, are always a little bit more well received because it's interactive. It's observed by the people who aren't participating, and then we sort of hockey team them in and out so that everyone gets to partake and watch. And then we do pretty well. I wouldn't say elaborate, but structured debriefings for those simulations that triple the time for each simulation.
Okay. Yeah, it'll be interesting to see. It's too much to go into in a discussion like this, but I can see the mixed methods. I will point out that's really something interesting that I've seen related to the flipped classroom. That got to be a super hot topic maybe 4 years ago, something like that, and people doing the lectures, beforehand and then discussing things. I have heard from at the graduate medical education level that not working as well, that the residents enjoy the discussion part of it, but they don't enjoy watching the lecture or doing the module before they show up. So I don't know if there's just something about just what your level of training is. It'll be interesting to see because I'm a faculty member on the American Society of Regional Anesthesia, and I sort of help motivate us to try that this year. So we're doing a sort of a flipped classroom model this year, and it'll be interesting to see what the feedback is. But I found that fascinating feedback, that the residents did. Yeah, first of all, they're too busy and they just want to take the time to do it, and they know they're going to get the session anyway. So there was a mixed bag of people coming prepared and didn't do the material, and then that makes it difficult to have the discussion in the way that you had planned on having it. Did you have
Yeah,
any sense of
yeah.
that?
So what I can tell you is that there is definitely a sweet spot in how long that module can be, because I try to keep them all under 25 minutes, just so that they can sort of consume it quickly, then come to the table with something to participate with. But where I did not abide by that rule was the mechanical ventilation module, which is a solid 50 to 60 minutes. And man, do I get some exhausted, tired comments about, oh, I wish I'd have known how long it was going to be. You should have broken it up into two. And mechanical ventilation is one of those things where it's hard to know when to even stop, especially if you've been doing it for a while, because you think all of it's relatively important. So there, I would say keeping it under 30 minutes is really good. I think 20 minutes would probably be great. It's just that for a 2 hour simulation experience, you feel like you might need more than 20 minutes of homework.
Yeah, and in a 20 minutes, you really can give leaving a starter coat of paint, on a topic. You can't really do it. So it's interesting. So yeah, I think this generation definitely is attuned to a smaller time frame in learning. There's no TikTok video that they're going to watch for 30
Exactly.
minutes. But yeah, okay, all right, great. Um, let's talk about another part of it, which I think is important for faculty to understand is, all right, you got a great project, you got some great ideas. This sounds like a lot of time and effort to actually put it together, although I imagine a lot of this is developed over a period of time. But so did you have to do any negotiating with your chair to try and get time, money, resources? What resources did you need and how did you negotiate for them?
So for the ICU extension and the clerkship was a substantial negotiation with the College of Medicine in order to give our department the time to permit us to direct that. So we showed them an outline of the entire structure of how the month would work, why it would make sense for us to do that, our sort of network in the ICUs, and they gave us some time, some protected time to be the directors of that and to teach in that. So the first thing we did was really discuss this with the College of Medicine, and they've been substantially helpful uh, to let us do that. And coupled to that is because it's through the medical school, we have access to the simulation lab, which is a high fidelity simulation lab that really allows them to become immersed and then broadcast that immersion to another room where the students can watch it, which then really creates this unique sense, I think, for them.
Again, I try to help junior faculty. So when you said you got protected time, did that mean that the School of Medicine provided funding to your department to then allow you to have protected time or others? And then
Exactly.
roughly how much protected time did they allow?
1 day a week,
Mhm.
so 4 days a month
Okay, for a year or for,
for yes, for the year.
okay, to be the clerkship director for
Yes, for that
anesthesiology.
additional time, exactly.
Okay, awesome. That's great. I don't know how many other programs would be able to negotiate that deal, but that sounds like a pretty good one.
Yeah.
And I think that's an interesting one about a novel approach. We're mostly trying to go to our chair to get something done, but in this circumstance, you went to the School of Medicine, who then funded, and then so your chair would have been happy to do it, if, of course.
That's exactly I think the important part is that your colleagues in the department and your chair realize that it's like NIH funding, right? It's being funded by somebody else. It's not on the skin of the partners. And
That's
that's where
right.
I think sometimes it's a little tricky is that, you're getting someone else out to, to do something that they're going to get awarded for or recognized for, and yet you're sort of permitting that exit.
So
And
I think the key point here is just to highlight to junior faculty then that potentially their medical schools can be a source of funding for educational projects that were around the medical students, and I don't think many would have known that right off the bat. I did have another question that I wanted to highlight, which was you said that your curriculum also highlights the teaching of non-technical skills. And obviously, the operating your simulation scenarios and the debriefing is a wonderful opportunity to teach non-technical skills. Can you tell us a little bit about how you approach the teaching of non-technical skills? And did you emphasize it in any way while they were actually in their clinical environment as opposed to in sim?
so I think one of the reasons why this clerkship has been so well received is because of this focus on non-technical skills, on behavioral economics, because it's something that resonates really easily in everyday life, let alone medicine. And and whether that's being a leader or being a follower, dealing with conflict, learning how to be situationally aware, having emotional intelligence, all these what we consider social skills are not developed in medical school, at least not universally developed, and seldom are they really recognized. And then when you get into the high acuity dynamic fields like surgery, emergency medicine, ICU, anesthesiology, they
Or
really are just
marriage?
are presumed to happen and taught, but they're not. And so what I've done is infused these ideas into the simulations without them being declared as part of the simulation. And then we go back and we start teasing them out a little bit. And it's sort of that, that eureka moment where this isn't about ACLS, really. This is about how we developed mutual trust or closed loop communication, or how we developed monitoring support, leadership. And of course, a sidebar is, okay, how do we deal with hyperkalemic arrest and the protocols that would go with that? But it's more like, who is the leader in that group?
Right.
When you ask for and so all of a sudden it becomes very translatable to the clinic. It becomes translatable to the floor, not just the ICU or the OR.
Did you find that most medical students don't get much training in terms of these types of non-technical skills?
For the most part, I ask them every month, whoever has had training about this, and the only people who usually say they know what behavioral economics are people who studied economics in undergrad. They learn conflict, but they learn conflict with a disruptive patient, not a disruptive partner.
So, different than like I'm familiar with the ANT system for anesthesia, non-technical skills,
Exactly.
and things like that. But how does, for those of us that didn't study economics, what is behavioral economics, and how is that different from what you were talking about teaching the non-technical skills?
I really think they're more of a different paradigm, looking at the same thing. So I look at anesthesia for non-technical skills. I look at behavioral economics. I look at emotional intelligence. I look at team steps.
Yep.
I,
But what
I
is
look.
what is behavioral economics for those of us that don't know
Yeah,
what you're talking
behavioral economics is really the science between decision making, the production, utilization, and really distribution of decisions, of ideas, and how we take these finite resources to deal with infinite questions, right? So in other words, how do we look at something that happens all the time and um, construct different realities around it?
All right.
You
I could
know,
see that I'm going to have you as back as another speaker, or put a toolbox module on just a little lecture on behavioral economics, because it sounds interesting. And I think,
what happened to me briefly was that when I started my at University of Florida, I was put as the one of the AODs, the person who makes the decisions, and you respond to the codes first. And I was like, wow, I just graduated. How am I going to help? And these people know a lot more than I do. And then so I looked into just how can I look for cognitive errors that they might have missed. So I went down this rabbit hole of cognitive errors that led me to behavioral economics that looked like a pretty blossoming field over the last 20 years, but it hadn't been applied to medicine. And so I found that really interesting and sort of started looking at it from a non medical perspective and then tried to employ it. And there is science on there about it, it's just very limited. And so that sort of brought me into teaching my residents about it. And then I decided to infuse that into the clerkship around 2015, 2016. And it's been pretty well appreciated, I think.
well, I normally try to keep these webcasts short and sweet, but I've got a super interesting speaker, and I just have to try to address two more things quickly if we can here towards the end. I apologize to our audience, but I think you'll find these two things interesting. The the next thing I just wanted to talk about is, can you just give us a brief description of the resident leadership development program that you do? Because I think in our discussions it was awesome. So
Yeah, so I think this actually segues just to what I was talking about. It started with this idea that there's these cognitive errors we make, and how can we get better at it? And I went down again, as I mentioned, the rabbit hole of this behavioral economics, and I found these really interesting ideas that I thought our residents would really like. And we would take pop culture books like Blink and Wait and The Invisible Gorilla. Um, and we would put them together into this book club, which we would read one book about every 6 to 8 weeks, and everyone would be assigned a chapter, and they would discuss it and present how they see this in their everyday life. And so
but
that
this
was
was a
your.
voluntary program.
Oh, it
This
was
was, just,
voluntary. Yeah.
only residents that want. It was open to anybody. If you want to participate, you can.
And so it
Okay.
started with 20 residents at my house every 6 to 8 weeks, with my wife and my kids going, who are these people in our house? And then it got to be so year 4 or 5, it got to be so big that I had to have two groups, because those 20, it was 40 people coming. So we would have roughly 15 to 20 people every month, but we would change the books because I just felt like it would get stale. So it became a 3-year seminar series on leadership development, um, on decision making, um, and it just kind of took on a life of its own. And so then we ended up on year 7, and COVID happened. So we sort of had to take a break. It's been 18 months, and I can't tell you how many people are asking me when we're going to start it again, including my chairman, who, by the way, funded this. So he bought all the books for everyone, allowed me a discretionary fund to buy food and drinks, and I had it at my house. And it was all voluntary, which was the part that I think was most novel, is that these people, just like every other resident, work until 6 p.m., would shower, and then come over at 7.
Yeah, that you're right. That's it's hard to put the residents are fully committed, right? And to add anything else into their schedule is a challenge.
Yeah,
Um,
and I
well,
guess I forgot to tell you one part is we would have a guest speaker come for the first 6 years, and the guest speaker would be really, the job is for me not to lead or the guest speaker to lead it. It's just to give us a little bit of practical wisdom on yeah, this happens. This really happens, and these are the problems that you see. And those guest speakers could be lay people like entrepreneurs or lawyers to the C-suite, like chief medical officer, CEO.
well, I know it might be just a teeny bit of work for you, but what I'd like you to ask is so that we can publish this along with this webcast. Your description of your either your curriculum syllabus or sort of whatever you for the regular 4th year rotation, just what topics that you felt like were important to discuss or have lectures or a flip classroom on. And then maybe as a separate document, though maybe some of the books that you've gone through in the last 5 years. That would be
Sure.
interesting to see. Your instead of Oprah's book club, we're going to have Chris Giordano's book club, and because then there might be other faculty members around that want to give this a whirl at their programs.
Yeah, I'm happy to. I put together a manuscript on this that I'm happy to submit as well.
Yep.
The struggle, I will tell you, the struggle was I started this without any intention of publishing it. And like I'm sure you'll attest to, if you're going to put this much effort into something, figure out beforehand how you could publish.
Well, at
What.
least get some advice. I think that's a great point. We should say that for the junior faculty is your chair will always, you might want to get some extra bang for something that you've done. Not only, you're the great thing that you did at your university, but something that's going to help you in your career advancement in some way, either whether your professional development or being promoted within your institution. And publication is certainly one method of doing that. Also can get you invited to be a speaker and some other things. So when you start with an idea, that's a great thing to discuss with the mentor is I've got this idea, I'm getting ready to do it. Do you think this is something that we would, could be published? And if so, that may alter just a little bit, the design of what you're planning to do, and to make it more publishable. So that's a great point. Well,
Yep.
I had a great speaker today and an interesting topic and from a different perspective. It was fantastic to have you on, Chris. Thanks so much for sharing your experience with the SCA
Yeah,
office.
I'll just follow with, you know, it has been very well received, and I think when you get the feedback that it's been well received, because I think everybody within our clerkship really is committed to this. I mean, I direct it, but it's really a department effort. But I can tell you, for the last 3 years in a row, we've won the clerkship of the year, which to me is a really impressive statement, considering 6 to 7% of students go into anesthesiology, and for it to win the last 3 years in a row mean that our residents, our faculty members are really committed to teaching these students what it's like to be an anesthesiologist and how it's really relevant to their career.
I think that's awesome. I think it's a great project. Thanks for finishing up with that. Chris, it was great to have you. And we look forward to maybe speaking with you again sometime.
Thanks for having me. I really appreciate it, Glenn.
All right, great. Thanks.
Take care.